Hello, everybody. Welcome to the Shark Tank, proudly sponsored by Quest Medical. We have Bloody Marys and mimosas in the back corners. Feel free to go and have a drink. My name is Parker Reinertson. I am the MPS sales manager for the Central Region. It's an honor to introduce Tyler Kelting. Tyler has been with Maine Medical in Portland for the past 13 years. Since 2019, he's been the director of perfusion services, leading the chain charge to improve safety and quality in open heart surgery through research and the best practices. Tyler is passionate about teamwork in the OR and creating a culture where everybody learns and grows together. He focuses on using data, technology, and patient care to drive innovation in cardiac surgery. At the core of everything he does in collaboration within the perfusion and across the entire care team, all to deliver the best possible outcomes for patients. Please join me in welcoming Tyler Kelting.
Awesome. Thank you so much, Parker. Appreciate those kind words. That good? Awesome. So just a quick disclosure. This talk is sponsored by Quest Medical. However, my thoughts, like many, are based on protocols, my own empirical data over the years, and studies done at our center, which we'll share a little more in depth during the talk. Some slides you'll see for visualization purposes we did obtain from Quest, however. So just a little bit about my center before I get into our talk. We're the #1 trauma hospital in the state of Maine. We do about 1,500 hearts a year, just continually growing and growing, which a lot of people, when they think of Maine, they don't really necessarily think of us as that robust of a center. In this bottom center of the picture here is the new $500 million cardiac tower they built last year, which we're very proud of as an institution. So I think we can all agree that healthcare is getting more and more complicated. How many people, just by a quick show of hands, have had a patient on ECMO while also being on another device such as an Impella or a balloon pump? The majority of us, right? How about that? And then also other devices, CRT, right, still there. It's becoming more and more complicated. We're seeing that it's becoming much and much more prescriptive, especially as technology begins to grow. AI algorithms are being built. They're starting this now. However, cardiac patients are just so dynamic, they can't exactly pinpoint the direct care they should be going. And of course, the reduction in permutations, standardization. We've been talking about that as a profession for the past decade. And I think we can all agree that we're finally at, universally, I think, a more standardized state than we were 10 years ago. However, and I promise I won't be asking questions every single slide, but how many people, by a show of hands, are using more than one type of cardioplegia at their center, whether it be surgeon-based, surgery-based, the majority of us? And this is where our center has found really great results with using the MPS, specifically the MPS 3 in the current years. It allows us to toggle back and forth. A lot of times we may get through the chest and then we think we're doing one thing and turns out we're not. We may start doing a surgery and it may be more advanced than we think it was when we got into it, especially on the adult congenital patients. And we can also use the vent line to help circuit salvage at the end of the case. It's a very versatile tool that can be used for several other things other than cardioplegia. However, FDA approved to only be used as such. So one of the famous authors wrote, "Adaptability is about the powerful difference between adapting to cope and adapting to win." Max McCowan, literally, if you read his book, it talks about establishing a vision and then going back and figuring out how you're going to implement that change to get there. And this is a lot of times what happens on the fly, whether it is a different surgery that we're doing, whether it is surgeon-based, whether it's volume-based. There's so many different variations of cardioplegia. It's the one thing I think as a profession we haven't quite been able to standardize completely. And I think it's just because the complexities of these case presentations are just so dynamic. So just a brief overview of it. And if you want to learn more, you can go to the booth. afterwards, and they can show you a quick demo. But in the upper left, I do just want to point out, because this is something that, we experienced at, our center, and honestly, it just goes to attribute the versatility that Quest has and was able to make this change. It tells you the temperature of the cardioplegia. After doing these about 20 cases, we noticed that, there was no alarm. And if you use the CardioQuip, depending on what heater cooler you're using, if you're constantly, continuously running the cardioplegia cold bath, it'll take away the ice block. So at the time, at least, there would be times intermittently where we would shut off the ice bath to the cardioplegia when we weren't giving. And then we realized it'd be great if there was a temperature indicator that would actually, you could set it to, and if it ever got above a certain temperature, you would get a notification. And we set it at 10, albeit we're in single digits all the time. So 10 is highly unlikely. I did a case last week and I was at 3 degrees. And then you can see the visual displays going across the board. It tells you what type of cardioplegia, the additive, the K, concentrations, the amounts. All of these, if you put in the concentration of the drug, it'll break it down to the milligram of what you're giving per dose and per ml. We also use it for graft perfusion, and you can actually say what grafts you're going down during those surgeries, and surgeons that like to use that graft perfusion. And one of the other benefits that we continuously use during this process is the pressure auto-regulation, where you can actually go up to a pressure of 130, hit a button, and it'll auto-regulate flow. As the surgeons working on the coronaries, we all know that flow can fluctuate as the pressure. However, putting it in this mode allows the pressure to stay the same and the flow to be the one that's adjusting. It's crazy when I looked at this slide, but I do think it's still worth bringing up, because I do think there's still centers that are doing this. But there was a time where we were spending around $7,000 per unit. We had 6 units for just over $42,000 a year testing and cleaning the heater coolers. It was just, we were using our own clinicians. Clinical engineering didn't buy into it at the time. So for us, the ND just seemed the common approach. It's literally a single disposable. You pull it out, put it in. When you're done, it's dripless, contactless, and then you throw it away and you start fresh. I can tell you, for me, having to deal with the regulatory and infection prevention people, this was a game changer. It was one of the easiest things to sell through capital after bringing this up. So as I talked about, and I saw many people raise their hands, all the different variations that you can have of cardioplegia. And I don't need to read the entire list, but I'm sure, at the very least, everyone in this room is probably used to using at least a third of them. If they don't do it on a daily basis, they've done it before in their training, they've seen it, they've heard about it. And I can tell you at our center, we did at least 2/3 of these before we started standardizing to microdelnito. So historically, about 5 years ago, this is what we gave, and it's still a huge benefit. And I think a good benefit for people that are just jumping into this space is starting to get into the blood cardioplegia. And we know the differences between blood cardioplegia, microdosing, benefits of hemodilution. We know the benefits of delnito, less surgical interruptions. The pitfall, of course, is the crystalloid. So when you look at what we switched to, which is a microdelnito, for every 1,200 of cardioplegia we give, which is typically our standard arrest dose, we give 19 mils of crystalloid. For those that give the 1 to 4, if you give 1,200, you're given 960. That's a huge difference. And in the world that we're talking about AKI and length of stay, blood transfusions, this stuff matters. I believe in marginal gains and making those where you can. And this is where we decided to go, and I will be the first to admit, I'm not the first to come up with this idea. There's several centers that were doing it when we decided what strategy we want to go, and I know there's hundreds of centers afterwards that are starting to look into it. But it's really combining the two. It's taking that hemodilution factor away from the crystalloid delnito, while also prioritizing the long length of time before interrupting the surgeons for having to give cardioplegia. So we're trying to figure out how we wanted to do this, because trying to get the exact chemical makeup of crystalloid delnito, which is what we wanted to do, and put it in this blood space, and we wanted it down to the milligram. So trying to figure out how much you can fit in, and at the time, a 50 cc syringe, and trying to get the chemical makeup, and then what ratio you have to set that to. It was a lot of whiteboard math with me and my senior perfusionist, Amy Phelps. So this was the chemical breakdown, and I will say, looking at it, I think we did a pretty good job. We were off 0.1 mil here, and maybe 100th of a mil there. But as you can see, it's the exact chemical makeup of the crystalloid del nido from a drug standpoint, without the crystalloid itself. And then just below, I showed the exact measurements of the delivery per dose. So you can see here, on this case in particular, we gave a total of just under 2 liters of cardioplegia. So that's the arrest dose and subsequent doses afterwards. And we had a total of 77 mLs of crystalloid giving. If we were using the traditional del nido that we used historically for years before, it would have been just around 1,500. I think at that point, if you're not transfusing, you hope that the patient's peeing well. Hopefully you're hemoconcentrating with that bunch of a upfront hit. And one thing I'll share later is, hemoconcentrating is not a benign event. So at the time, we talked to our pharmacy. They wanted to make sure there was a third-party validation, which we got done. So CAPS actually did a 503B development QA validation, stability studies on it, because this was the most requested formula from them. It actually turned out, a lot of times during this talk, people ask what the dollar amount is. I honestly couldn't tell you now, because we do make it internally after seeing the great results of it. But I know at the time, based on volume, it was worth savings. And the biggest thing is it was good for 45 days, which, is a really long time, especially for this type of chemical makeup. So this is just a picture of our heart-lung machine that we decided to go with on the left. I will say, personally, I think this is the best, setup you have going. And it's also just a great picture of amazing collaboration between Spectrum Medical and Quest on getting the results completely inputted into Spectrum. We were kind of one of the first people that were trying to link these together, and they got together in the matter of weeks. We had everything up and running. And to have that data at the key of your fingertips that we can go back and look into, also from a registry standpoint, is an amazing thing. And one of the things, additionally to cardioplegia, because I talked before about getting these marginal gains, this is just one of them, is also trying to identify these patients that would identify or would benefit from this type of protection. And just a couple of these papers, we won't go into deep details just for the purpose of time, but just one paper showed specifically, even if you give iron preoperatively as early as 24 hours, there was a positive change in hemoglobin concentration, reticulocyte concentration, which, remember, those are those immature red blood cells, and helps with adverse events. And then also the other study from the Annals of Thoracic Surgery looked at over 24,000 patients, all risk adjusted, independent of center variability. And they noticed that there was a 9% increase in 30-day mortality, 7% greater major morbidity, and a 4% greater chance in minor morbidity for every unit of blood given. So despite crystalloid del nido being a great thing, we had great results. We're hands down transfusing more. How do we know that? Which goes to my last part of the talk, is making sure you're actually measuring your results. Making sure you're not coming up with this out of thin air, but you're belonging to registries, whether local, national. Get a part of something. You have to have something to measure, some type of goal and some type of way of figuring out how you're going to get there. This is showing our reoperation for any cardiac surgery or for isolated cabbages. And although you see big bumps and dips, it's also important to look at the scale. But 2025 data isn't out just because it's always a year behind. But you can see, we're under that 3%, and a lot of times in the third quarter and the fourth, under 2%. For bringbacks. And then this is reoperation for all bleedings. And, we do pretty much anything under the sun other than transplants. And, for the past 3 quarters, we've been under 4%, which we're just constantly trying to figure out better ways. This is our transfusion rates over time for isolated cabbages. You can see how we've continually been trending down since 2001. It's a conscious effort. And the more you can share this with senior leadership and other departments, specifically your surgeons, the more this stuff is going to stick. And then here's our transfusion rates. And you might ask, like, why? It almost looks like the graph's cut off. And it's because once you hit so many metrics for so long, it actually had to reset the scale. So now you actually reset the scale in a good way. So we're actually, you know, in the past 2 quarters on each other under 25%. And then this is just an example of some of the stuff that, you know, we're trying to also do, you know, in conjunction with Quest on making sure that we're trying to, you know, prevent blood transfusions as much as we possibly can. And these are, you know, recent studies. We're looking at area under the curve. We're looking at thresholds. John St. Odge is doing amazing work at our center right now, pulling a bunch of registry stuff. We have a bunch of issues going through the IRB right now, so I won't talk too much about it, but I'm hoping that next year I can come back with some amazing results on this. And then just some future considerations. Some of this work on my right, and I apologize, it's kind of granular, but at the end of the day, you know, when I did a study, I wanted to look at AKI rates, differences between microplegia and crystalloid del nido. And although I could find nothing statistically significant between giving one or the other as it relates to AKI, one thing was a confound factor that correlated the both. And it was if you hemoconcentrated, you had a greater rate of AKI. Now, is it because we hemoconcentrated, or is it because those patients are already in that state? Nevertheless, for micro del nido patients, we're only at about 5%, where with crystalloid del nido patients, we were at about 17. So we're already cutting it in a third. And then lastly, I just want to take a second to thank Quest for allowing me this stage and platform to share some of the stuff we're doing at our center. And then on the bottom right here, just recently in the past 6 months, we partnered with the Rue Institute. And as I talked about, you know, earlier in my talk about those AI algorithms, we're actually taking data from Quest, from our registry, pumping it into our own server, and then looking at it with post-operative variables. Right now we have a grant, and we're looking forward to publishing this in the near future. And same thing, exciting stuff. So once again, thank you very much, and appreciate the time. Are there any questions? Does anyone have any questions? If not up here, you're welcome to get me off stage, and I'm happy to answer whatever there is. Awesome. Thank you.
Tyler, we have one question online for you. It states, what if you have supply issues? Can your pharmacy compound such a product? Are there other ways of obtaining it if they cannot?
Our pharmacy does make it now.
But also a perfusionist could enter the drugs?
No. In the United States with USP 797 guidelines, you can't allow any compounding with perfusionists, so it has to be through the pharmacy. So most likely your pharmacy and regulatory is going to push back if you as a perfusionist want to make it in the OR. However, we have our pharmacy make it underneath the hood, which is regulatory guidelines, and then they'll bring it down. We have a fridge that they'll put it in this lock.
Okay.
So this came up during Mr. Baker's talk as well, but a lot of people are looking for literature comparing del nido to the micro del nido or KBC. Do you have any direction for us where to look?
It's definitely out there. Well, we started it probably 5 years ago, and there was 4 or 5 papers on it.
Okay.
And this is part of what John St. Onge is looking at right now. That's where I was saying that he's going through the IRB. So because of that, I want to make sure we're doing it the right way, and we haven't looked at any of the data yet. But that's our biggest thing, and also been kind of a frustration. Like, yeah, we see it works. I've talked to other centers that have also agreed, but it'd be nice to have the big white paper that shows that as well.
Who else has a question?
Thanks, Tyler. That was a lovely presentation. Hey, you showed us a few control charts, and then you showed us the control chart where you changed your scale. Would you Would you like to talk to us a little bit about the practice changes that occurred leading up to that requirement to change your scale?
Yeah, so we actually had a whole protocol. We called it the BRAX trial, the bleeding reduction after cardiac surgery. And it was it was a whole systematic change from pre-op, which was part of identifying those patients and giving them iron when we could. And then intra-op, we would actually have, which was, I couldn't believe it. The surgeons actually bought into it. That's one of the hardest things when I say this. They're like, there's no way. But there was a 5-minute bleeding pause where they literally had to make sure they couldn't do anything with towels. Then there had to be a 5-minute bleeding pause just because we were closing so quick. That was one of the things we did intraoperatively. And then post-operatively, historically, they had a 2-liter free rein, which means if there's a patient that came up, they could give up to 2 liters of Normasol to hemodynamically stabilize that patient without any order set, without any direction from surgeon. So we minimized that down to 1 liter, and also they had to have a discussion with the intensivist before any bolus of fluid. So those were kind of the biggest things that I think drove that downwards.
Thanks.
Yeah.
I have another one from the live feed. Somebody's asking about recommendations for equipment failures, and I think what they're getting at is that there's more safety features built into the MPS 3, like a backup battery. Could you maybe explain some of those?
There's a backup battery. Yep.
Okay.
There's a backup, yeah.
Hello. So in addition to the backup battery for power failure mode, there's also if you're used to the MPS 2, the backup hand crank system, the bus, that has been replaced on the MPS 3 with what we call the emergency bypass line. And it takes blood volume directly from your line that comes out of your oxygenator that would normally supply the Quest into the internal pumpings, and takes it from that line straight to the heat exchange, where then you can manually push in your drugs if you were having an emergency situation where you didn't have the pump, and it functions off of the back pressure of the oxygenator. You can get about 300 of flow.
What she said.
Anybody else out there have a question for Tyler? I have another question.
Sure.
We worry sometimes about lidocaine toxicity in Del Nido cardioplegia.
How much Del Nido cardioplegia are you given?
Well, some of us are given 3 and 4 liters, as we found out in some of the talks earlier today.
Yeah, so our standard, and same thing. So we standardize this across the board with all the surgeons. We give 1,200 total, and then we remind at 45 minutes, and then every 15 minutes after that. If they don't think the clamp's gonna come off within an hour total, then they'll think about redosing. Typically, our subsequent doses at that point are 400.
400.
Yeah.
Do you vary the concentrations at all, or the concentrations stay the same?
So we do have one surgeon that mixes the constant, just as like a high and a low, but the other 7 just all standardized across the board.
On the MPS 3 and the MPS 3ND, at the end of your case or at any point during your case, just as long as you're not actively running cardioplegia, you can hit your volume button, and then inside of that, another menu is going to populate. There's a dose summary button. You can click on that, and it will itemize all of your drug calculations that you've given to the milligram. So you know exactly how much lidocaine you've given when the cross clamp comes off. So if you decided that maybe I've given too much and I'm going to hold back on that bolus, that's don't give the 100. Or if you're like, there's only 150 given, you can go ahead and give your 100. Yeah. So.
I will say too, we've had instances where we've given microdel-nido, clamp comes off, surgeon realize they need to go back in to do something. They know it's going to be a short cross clamp time, less than 15 minutes. We'll just convert right over to microplegia on the fly. It's literally a 10-second process. Yeah.
I have another question online. Somebody is concerned about the viscosity of a high hematocrit being cooled and trying to get through blockages for the cabbage patients. Is there any data or you have any concern for that?
I don't have any. We've never had any issues with that at all. We do give antegrade and retrograde. I will say to that fact, we typically give 600 antegrade and 600 retro on the majority of our surgeries. I'm just trying to think because there's one that typically only gives antegrade if there's no AI. But other than that, we do make sure we give antegrade and retrograde. And I will say too, it always amazed me. You have these patients that come in with a fresh MI and you just imagine their myocardium is just craving oxygen. And for the longest time, we, as well as other centers still do, you give that crystalloid del-nido and like very little of it is RBCs. And then you hope the distribution is good because you're not going to be touching it in 45 minutes at the very least. And yet the outcomes were great. They were no different at our center, which always just amazed me.
Yeah, I agree with that.
Yeah.
We're so worried about the DO2 in the kidneys
Yeah.
right now, but what's the DO2 in the heart during cardioplegia delivery?
And this is more just my own anecdotal information about high hematocrits. I used to work at an academic center where we had one surgeon and one anesthesiologist that specialized in doing people who would with a religion that did not accept blood products. So they would often go to clinic for infusions of EPO and get their iron and have like these insane hematocrits when they walk in the room. And we used the Quest MPS system there, and I can tell you that even with like something in the 40, we did not see any different. That was with standard microplegia, not with the microdel-nido, but with standard microplegia, we saw no problems with it.
Yep.
Also, several comments in the chat that people are jealous we got Bloody Marys and they didn't have one at home. Does anybody else have a question? Well, let's give our speaker a round of applause.
Awesome. Thanks.